overdose and withdrawal. Now, on the NCLEX, you're obviously going to have to know a lot of different kind of pharmacology questions, but you should know as well street drugs and drugs that are used for recreational use. And there are two categories of drugs that are used recreationally. They fall into one of either two categories. One, they are uppers. So on the left-hand side, they are uppers or downers. Okay. Now, why are there only two categories? Well, if something doesn't make you feel up and it doesn't make you feel down, then why would anybody abuse it, right? You never hear of somebody abusing something like, aspirin, right? You take an aspirin, it doesn't make you feel any particular way. It might relieve some pain, but it's not going to make you feel high or feel low. So it's either an upper or a downer. There is one exception, and that is going to be laxatives. Laxatives are abused, but it's not for the same reason that patients abuse every other drug. Laxatives are typically abused in weight loss situations, which is more of a psych-related condition than recreational drug use. So drugs fall into two categories, either uppers or downers, and you got to know them all, okay, which categories that a different particular drug would fall into. The good news is this. If you memorize the uppers, you don't have to memorize the downers, because if it's not on the uppers list, then it must be a downer. Now, the even better news is there's only 5 uppers. Okay, so you have to memorize 5 drugs, and you can figure out all the rest of them. The 5 that you need to memorize that are the uppers are, number 1 is cocaine. Number 2, methamphetamines, which includes speed, crystal meth, kind of stuff. The 3rd is PCP and LSD. The 4th is caffeine. And the 5th would be Adderall or Ritalin. Okay, and the Adderall Ritalin really falls under methamphetamines, but kind of in a different way. So those are the 5. Cocaine, methamphetamines, PCP or LSD. 4th is caffeine, and the 5th is Adderall, Ritalin. So what are the signs and symptoms now of somebody who is on an upper? Okay, this is pretty straightforward. Everything's going to be elevated on them. Are they going to have tachycardia or bradycardia, right? They're going to be tachycardic. They are going to be irritable. They're going to have agitation. They could have clonus. They are going to be tachypnic. These are people that are going to be elevated, okay? They are not going to be feeling depressed. That's why they took them, was to feel elevated. So what are the downers then? Okay, what are the names of the drugs that are downers? Well, there's over 100 of them, so don't memorize them. Just understand that if it's not on the other list, then it must be a downer. Okay, so if it's not one of the 5 you memorized, it's a downer. So this is stuff like morphine, alcohol, weed, Ativan, hash, heroin. Okay, those are all examples of downers, but don't memorize that list. Okay, if it's not on the list of uppers, it's a downer. And then signs and symptoms of downers. Okay, well, everything's going to be depressed, so they're going to be bradycardic. They're going to have a decreased level of consciousness, decreased deep tendon reflexes. You could have a whole list, but you don't need to memorize it. You just need to know that everything in the body is going to be depressed. For overdose and withdrawal, there's 2 things you need to consider. On the left-hand side for overdose, in overdose you have too much of the substance. Okay, so there's too much of the substance causes an overdose. So what does that mean for your body? Well, with too much of an upper, everything in your body is elevated. And with too much downer, everything in your body is depressed or decreased. Okay, so that's pretty straightforward, but what about in withdrawal? Well, in withdrawal, you have too little of a substance. So if somebody comes to you and says, if they're an addict, that you need to know what drug they were on, because that will tell you what they will be experiencing. So if somebody is experiencing too little upper, then everything will be down. Because if they're constantly using that upper, they just get used to that, okay? And that's their normal state. They may still be exhibiting elevated signs and symptoms and functionality, but they get accustomed to it. So if you take that away, they're going to be experiencing a depression. Okay, so with too little upper, everything is down, everything is depressed. And so the opposite holds true as well. With too little downer, everything is going to be elevated. Okay, so if somebody's not using enough of their pot or their heroin or their Ativan or alcohol, they're going to be experiencing an elevation in their signs and symptoms. So they are going to be having, you might see stuff like clonus or tachycardia, because we know that with too little downer in an addict, everything will be elevated. Okay. So for newborns, in a newborn, you want to always assume that there's an overdose. Okay. And that you want to do that for the first 24 hours. You want to assume overdose for the first 24 hours in a newborn. You don't want to assume a withdrawal. But what's going to happen to that baby after 24 hours? Okay. If they were in a state of overdose and now you take that away from them, they're going to be experiencing what we just talked about. So if the mom was on cocaine, the baby's going to come out high, right? And it's used to being high. And when you take that away, the baby's going to become depressed. But if the mother was addicted to heroin and the baby comes out, the baby's going to be overdosed, but in a depressed state. But when you take that depressant away, that baby is going to become very irritable. Okay, so you need to be prepared for that. So in a newborn, always assume overdose for the first 24 hours and not withdrawal. Let's talk about AWS versus the DTs. AWS is alcohol withdrawal syndrome, and DTs is delirium tremens. So every alcoholic experiences AWS, but not every alcoholic goes through the DTs. Okay, so it's important to understand that AWS is not life-threatening, and the patient is considered stable. But you don't know if they're going to end up going through the DTs. And DTs can be lethal. And so these patients should be considered unstable and dangerous. Okay, so AWS is not life-threatening and the patient can be considered stable. But DTs can be lethal and the patient should be considered unstable and dangerous. So, timetable here. Let's look at the differences between AWS and DTs. AWS occurs in the first 24 hours after removal of the alcohol. Okay, after they stop drinking, it's going to start kicking in pretty much immediately and go for the first 24 hours. Okay, so down that left-hand column, you can write down, where do you put this patient? You put this patient in a semi-private room, and you can put it anywhere. It's fine. If you put these patients anywhere, they can be far from the nurse's station. They can be with a roommate. No big deal. They're going to be on a regular diet. Put that in the second row. In the third row there, they can be up at lib. There's no bed rest, anything like that. And they don't need to be restrained. That's the last thing in that column. Now, in the column for the DTs, it's the first 72 hours. Okay. These patients need to be in a private room and near the nurse's station. Okay, because remember, they're unstable patients, so you would not put an unstable patient far from the nurse's station. Diet-wise, they're going to be NPO, put that in the second row. They are going to be unrestricted to bed rests. Okay, so they're not going to be allowed up to go to the bathroom. You're going to have a bedside commode or be using a bedpan. Okay, and likely they will need restraints. Okay. So they will be most likely 2-point restraints, okay? Now, you don't need 4-point restraints for these patients, but they do need to be restrained. They are a danger to themselves and to others as they're going through the DTs. So you'll choose one arm and the opposite leg to restrain. When it comes time to switch the arms and legs that are being restrained, because you don't want to, pin down their right arm and their left leg, for the entire day. So when you go to switch, they will be briefly in 4-point restraints. So you'll restrain all arms and legs and then release the opposites. You don't want to release them so that they are in 2-point restraints on the same side. Okay. Now, they are both going to need antihypertensive drugs. Okay. These patients get headaches. Right, so they need antihypertension drugs. They will likely be on a tranquilizer, typically Ativan, and they'll do the CIWA score, CIWA. All right, and that is a score that looks at the signs and symptoms of your client and what they are experiencing, and they'll probably be given B1 in their diet. Right? B1 is thiamine. Thiamine is essential in alcohol metabolism. Okay. Now, for restraints, when we are restraining a patient, it's going to be a whole lecture, I understand, but real quick, for restraints, you need to make sure you visualize the patient every 15 minutes. Okay, so you're looking at the patient every 15 minutes, putting your eyes on them, making sure that they are okay. And you want to rotate their arms and legs that's being restrained every 2 hours. Okay. So that's the basis of what you need to know for overdose and withdrawal on the NCLEX. So again, memorize the 5 uppers. You don't need to memorize the list of downers. Uppers make you feel up. Downers make you feel down. In overdose, you have too much of whatever it is, the upper or the downer. So too much upper, everything's going to be overly elevated. Too much downer, everything is going to be overly depressed. Okay, when you start to withdraw, you're having too little of that substance. So you need to know what kind of drug the patient was on to determine what they will experience during withdrawal. So if they have too little upper, they're going to be experiencing a depression. And if they have too little downer, they're going to be experiencing an elevation. Okay? Remember, in newborns, always assume overdose for the first 24 hours, and after that, they are going to go through withdrawal. For AWS, understand that every patient who is an alcoholic will go through AWS, but not all of them will go through DTs. You don't know ahead of time which will go through which. So remember, AWS is not life-threatening. The patient can be considered stable. And for DTs, they can be lethal. And the patient should be considered unstable and dangerous. All right? So that's the highlights of what you need to know for overdose and withdrawal for the NCLEX.